So somebody wanted to know about vestibular migraine and how it comes to neuro-ophthalmology. And as you can imagine, the vestibular system can come to neuro-ophthalmology in different ways. And one of the ways it comes to us is when the eye is clearly the problem. The other is when it's the brain that's the problem. And the other is when it looks like the ear, but it's not the ear, but it's still a problem. So the way we're going to look at this is if we have vestibular symptoms, dizziness, vertigo, subjective motion in the environment, which is oscillopsia, subjective motion in the environment, illusory rotation, which is vertigo, and the feeling of imbalanced dizziness, these are all vestibular symptoms. So those symptoms can arise from damage to the end organ. So if you have a problem in your ear, that's going to be a peripheral vestibulopathy. And if you have unilateral dysfunction in the vestibular system, that's going to produce the characteristic symptoms: hearing loss, tinnitus, vertigo. The common things are benign positional paroxysmal vertigo, Meniere's disease, labyrinthitis, things that damage the peripheral vestibular system. And so ENT is going to have some tests like the Dix-Hallpike maneuver to look for peripheral vestibular dysfunction. If it's the eye that's the problem, we're going to see the nystagmus. And the nystagmus that we're looking for is purely vertical, downbeat, or purely upbeat, or purely torsional. These purely torsional vertical nystagmus forms mean it's central. So the eye examination tells us it's central because the semicircular canals cannot produce these purely rotary or purely vertical because they're not oriented in that way. And if it's a horizontal nystagmus, that could be still peripheral vestibular, but it has to be unidirectional because it's only one unilateral vestibular system that's bad. If it's a bidirectional horizontal gaze evoked nystagmus, that is also central. So your job as the ophthalmologist is to make sure it's not one of these pure nystagmuses, to think about peripheral vestibulopathy, and if we have diplopia, that can't come from your ear. So that's the test of Skew. And in the acute phase, the head impulse test is what we're going to be using to detect that unilateral vestibular hypofunction. Over time, though, that test isn't as good. So that's for like the ER, and you can watch the video on that one. So once we've determined that the eye exam is normal, or we detect the nystagmus, or we detect the Skew, then we have to image the brainstem because that's a central vestibulopathy. Now, one of the causes of this central vestibulopathy is migraine. And so if we have a normal eye exam, a normal peripheral exam, and the patient meets the diagnostic criteria, the International Headache Society criteria for migraine, and has 5 or more episodes of vestibular symptoms with a normal ear and a normal eye and a normal MRI, then you can make the diagnosis of vestibular migraine. So it's the vestibular symptoms, but it's a rule out. Rule out peripheral, rule out central, rule out ocular before you call it vestibular migraine, and it has to meet the already established criteria, IHS criteria for migraine.